We are live.
Good evening, everybody. I welcome you all to today to iFocus online session. Today we are in lecture 535, Optics and Refraction, module 10. Today we are going to learn about notation of lenses, spectacle prescription, simple and toric transposition by Dr. Prateeksha Sharma, ma'am, who's associate consultant at Center for Sight, Haryana. Welcome, ma'am.
Thank you, Kritika.
To moderate today's class, we have Dr. Deepa Gupta, ma'am. Ma'am is a senior consultant, cataract, cornea, and refractive surgery with HOD. She's also HOD and co-partner at LAL 2020 Eye Care and LAL LASIK Center, Gurgaon. Ma'am has performed over 20,000 cataract surgeries and 1,000 plus corneal transplants. She's expertise in LASIK, SMILE, ICL, cross-linking procedures, keratoplasties, and ocular surface surgeries. Ma'am has a special interest in keratoconus management and premium IOLs. She's been actively involved in teaching, presentations, and live surgeries in both national and international conferences. Ma'am has served as moderator, panelist, judge in academic sessions for 10 plus years and has performed live cataract surgery in WAS 2023. She's also a winner OPL Trophy AIOS Kolkata 2024. Welcome, ma'am. Uh, we have a special respected ma'am to chair the session today. Major General Dr. Sagarika Patel, ma'am. She's finished her MBBS from Calcutta Medical College, DO and MS from Army Hospital, Delhi. After which she did a glaucoma training from RP Center, AIMS. Ma'am is a gold medalist, rank on a silver casket for standing first in surgery in the Calcutta University. Currently, ma'am is a senior consultant at Center for Sight, New Delhi. She has served as the Assistant Chief of Integrated Defense Staff Medical at Army Headquarters, Delhi, HOD of Ophthalmology at Army Hospital and at Army Base Hospital, Delhi. She has served as a professor at AFMC Pune. Ma'am is the only lady officer to have commanded the world's highest general hospital at Leh, where she was instrumental in establishing telemedicine nodes in high altitude to help soldiers stationed in the highest battleground in the world. Ma'am has received the Vishish Seva Medal in 2016, Sena Medal Distinguished in 2014, Chief of Army Staff Commendation in 2004 and 11. Few are among other prestigious awards. She's active in research, has over 78 publications and with 278 citations, both in international and national peer-reviewed journals. Ma'am has written chapters in books and has edited a book, Resolving Dilemmas in Perimetry, Resolving Dilemmas in Ophthalmology. She has held innumerable instruction courses in national and international conferences, especially in glaucoma and myopia. Ma'am is recognized as a supervisor to guide PG and diploma students, UG and PG teacher and examiner. She has also served as MCI inspector for MBBS, DNB, National Faculty for Glaucoma, and faculty in DOS PG teaching program and iFocus. She's serving as a reviewer for the index journals such as MJAFI, Journal Clin Ophthalmol Research, and DJO, MDPI, and Curious Medical Publishing online journal. Welcome, ma'am. It's an honor to have you here today.
Thank you.
And our speaker for today's session, Dr. Prateeksha Sharma, ma'am, our lovely mentor. Ma'am has finished her MBBS from Lady Harding Medical College, MS from Maulana Azad Medical College, after which she did a senior residency from Guru Nanak Eye Center, Delhi. Currently, she's an associate consultant at Center for Sight, Haryana. She's previously worked as specialist ophthalmology in ASI Hospital, Haryana. She's a recipient of Champions Award at UC. She's a distinction in medical training. She's authored over 30 journal articles and given over 40 presentations and lectures at various ophthalmic meetings, national and international level. Welcome, ma'am, and over to you to begin the presentation.
Thank you, Kritika. Yes, Kritika, is my slide visible?
Yes, ma'am.
Okay, so let's start with today's topic. So the today's topic is geometric optics, notation of lenses, spectacle prescription, simple and toric transposition. So starting with the notation of lenses, let's come to the introduction. Understanding lens notation is a fundamental skill in ophthalmology, and ophthalmologists frequently prescribe, interpret, and transpose lens prescription. This section introduces the basics of spectacle prescription, their history, and importance. So coming to the historical background of lens notation, Early ophthalmology prescription used inconsistent systems. So over the time, two main notations involved: the plus cylinder system, which is used by ophthalmologist, and the minus cylinder system, which is used by optometrist. Knowledge of both is essential for clinical practice. Then basic optical principles. Lens as lenses alter the path of the light by refraction, understanding the sphere, cylinder, axis helps in writing and interpreting prescriptions. The spherical component connects the myopia or hyperopia, as we all know, and the cylindrical component collects the astigmatism, along with the axis, which indicates the orientation. So the ophthalmic lenses are described using standardized notations that communicate their power, type, axis, and design. The most widely used are spherical cylindrical notations, sphere cylinder axis notation, and transposition method. Coming to spherical lens notation. A spherical lens has same power in all meridians, as we all know. It is denoted by plus or minus diopter. Example, +2 diopter means convex lens for hyperopia, and -3 diopter means concave lens for myopia. Cylindrical lens notation. A cylindrical lens has power in one meridian and no power in the meridian at right angles to it. It is used to correct astigmatism, and the notations are minus cylinder notation, which is commonly used in US, and plus cylinder notations common in Europe and among ophthalmologists, especially in refraction tables, retinoscopy, and autorefractions. Example, -2 diopter cylinder at 180 degree. It means 2 diopter cylinder axis at 180 degree. Then sphere cylinder axis notation. This is the most standard way prescriptions are written. It combines the sphere, which denotes myopia or hyperopia correction, cylinder, which denotes the astigmatism correction, cylindrical power, and axis, which is orientation of astigmatism, which is given in degree from 0 to 180 degree. The format of spherical consists of the spherical value, which is written first, then an oblique sign, followed by the cylindrical value into the axis. Example, -2, which is the spherical power, -1.5 cylinder at 180 degree. So this is myopia with astigmatism minus cylindrical format. The another format is plus cylindrical, which is +3 and sphere +2 cylinder at 90 degrees. So this is for hyperopia with astigmatism plus cylinder format. Coming to cylindrical transposition, here I will just cover a little bit about it. We will go in detail about this in the other part. So since the cylinder can be written in plus or minus form, ophthalmologist must know how to transpose. So what are the rules of transposition? We add the sphere and cylinder and new sphere is formed. We also change the sign of cylinder minus to plus or plus to minus, and we rotate the axis by 90 degrees. This we will study in detail in the later part. Now, example of transposition when you have +2 diopter of sphere and -1 cylinder at 180 degree, which is a minus cylinder form. And you want to transpose it, so you add the two. You add the sphere to the cylinder. What comes out is the 1 diopter of sphere, the plus power. Change the sign of the cylinder, which goes from -1 to +1, and then you add 180 degree plus 90 degree, which is 270, but it is written in scale of 0 to 180. So in such case, we will subtract 90 from 180 degree. So it will come out as +1 diopter and as sphere and +1 cylinder at 90 degree. So what is to be remembered is that the axis is always donated between 0 to 180 degree. We should not increase above 180 degree. Then coming to spherocylindrical mixed notation. So combination of spherical plus cylindrical component. It corrects both spherical error, which is myopia or hyperopia, and astigmatism, which is noted as sphere cylinder into axis. Next is prism notation, sometimes added to correct the strabismus or binocular vision anomalies. It is expressed as prism diopters or base direction. So it could be base up, base down, base in, base out, which is denoted by BU, BD, BI, BO. So example is written -2 diameter of sphere, -1 cylinder at 180 degree with 2 diameter of prism, base up, base out. This is how it is written. Then contact lens notation, usually given as base curve, power, diameter, cylinder, and axis. All these things have to be mentioned whenever we are prescribing a contact lens. So example is 8.6 base curve, then comes the power, which is -3 diopters, then comes the diameter of the contact lens, which is 14.2 millimeters, and then comes the cylinder with the axis, which is -1.25 at 180 degree. So what are the various abbreviations which are used by ophthalmologists in their prescription? It is DS, which denotes diopter sphere. There is no cylinder. DC is diopter cylinder. Then VA means visual acuity with that lens. OD is right eye. OS is left eye. And OU is both eye. Now the thing to be remembered here is always mention OD first and OS after it. Then example in record, OD is -2 diopters with visual acuity of 6/6. OS is -2 diopter sphere, -1.5 cylinder at 90 degree, visual acuity of 6/9. Coming to spectacle prescription, we will study in detail about it. Now, why a spectacle prescription is important? Because it is a legal medical document which is provided by an ophthalmologist or optometrist. It conveys the exact refractive correction required for a patient's eye. Incorrect prescriptions can produce symptoms like headache, asthenopia, diplopia, blur vision, distortion, and intolerance. So what is the main purpose of giving spectacles? First is to correct the refractive error, myopia, hypermetropia, astigmatism, presbyopia. Then second, it also provides prismatic correction for ocular deviations, which we have already seen that how to prescribe a prism. Then it gives comfort for near and intermediate tasks also. So these are the purpose which we have already discussed. Now, what are the details that should be mentioned whenever we prescribe a spectacles? Besides our clinical description of the spectacles, we should also mention, we should not forget to mention the name, age, and gender. Why it is important? Because presbyopia is age dependent. Then you should try to mention the occupation also. Why? Because computer versus fine work versus driving, depending on the occupation, patient can choose that particular lens, that particular material, which will help them in their profession. That also we will come discuss in detail a little later. Then refraction method. What is the method you have used to prescribe the spectacles, whether it is subjective or cycloplegic, and date of prescription. Secondly, then you write about the eye notations. So very important to write the prescription of the right eye first. So OD, what is the full form of OD? It is oculus dexter. Then OS, which is the left eye, is oculus sinister. Then OU, which is both eyes, oculus uterque. Then right eye, left eye, modern notation always replaces OD and OS. Coming to spherical lenses. So what are the spherical lenses? Spherical lenses are equal curvature in all meridians. What is the effect? They move the focal point forward or backwards. So what are the notations used for spherical lenses? We have positive for hypermetropia, negative for myopia. What is the unit used? It is diopter. So example of a spherical lens is +2 OD, that is right eye, +2 diopter sphere. What does it stand for? That +2 convex lens for hypermetropia. Coming to cylindrical lenses, what is the definition? What is a cylindrical lens? It has a refractive power only in one meridian. Where our spherical lens has refractive power in all meridian, the cylindrical lens has in one meridian. It corrects astigmatism, where cornea or lens has different curvature in different meridians. What are the notations used? Positive cylinder, which is plus, it adds the convex power. Negative cylinder, which is minus, it subtracts the power. Then you write the axis. As I already mentioned, the axis has to be written between 0 to 180 degree only. So axis denotes the meridian without cylindrical power. Example, -2 diopter at 90 degree means the cylindrical lens of -2 diopter acts at 180 degree. So axis is expressed in degrees from 0 to 180 degree. Very important is to mention axis very accurately. A small axis error more than 5 degree can significantly reduce the visual clarity in astigmatism. Coming to prescribed in prism diopters. One prism diopter means displacement of image by 1 centimeter at 1 meter distance. It is used in strabismus, convergence insufficiency, and diplopia. We must specify the base direction. So first you have already described the power of the prism in diopters. Second, you have in the base direction, whether it is up, down, in, or out. For example, 2 diopter of prism with base out, 3 diopter prism with base up. This is how we prescribe a prism. Next is additions, which are given in case of presbyopia. Extra plus power for near vision in presbyopia. Usually it is +1 diopter to 3.5 diopters depending on. So typical values which are mentioned is at 40 years we usually give +1 to 1.25, 45 pay 1.5 to 1.5, 50 years it is +2 diopters, 55 years up to 2.5 diopters, and 60 years it is +3 diopters. Next comes the pupillary distance, PD. It is again an important component of our spectacle prescription, which most of us miss. Now, why this is important? It is very essential for centration of optical centers, especially in cases where we prescribe progressive lenses or advanced lenses. It is very important to measure pupillary distance. Usually, the monoocular pupillary distance is 31 millimeter. And how do we mention it? Like OD 31 millimeter and OS 31 millimeter. And binocular, whenever we measure the binocular pupillary distance, we do not write OD or OS. We will also see how can we measure monocular pupillary distance and binocular pupillary distance. So near PD is slightly smaller due to convergence. So 3 important things which we have learned. First is that pupillary distance has to be mentioned whenever you prescribe spectacles. Secondly, you should mention, it is more accurate to mention the monocular pupillary distance of right and left separately. Otherwise, you can also do binocular. Then the pupillary distance for the distance and near should be measured differently. It should not be same. Now coming in detail about pupillary distance, how can we measure the pupillary distance and what is pupillary distance? So the definition says that the pupillary distance is a distance in millimeters between the centers of the two pupils. It ensures that the optical center of lenses align with the patient's visual axis. That is why it is very important to measure the pupillary distance. If you measure it incorrectly, it can cause prismatic effect, eye strain, diplopia, and headache. So whenever a patient comes back with new spectacles, which you have prescribed and complaints of such effects like eye strain, diplopia, and headache, we should check the spectacles whether the pupillary distance was mentioned and incorporated or not. Then types of pupillary distance. So whenever we mention the distance PD, how do you measure the distance PD that is for the far vision? It is measured when the patient looks at a distant target more than 6 meters. Eyes are in parallel gaze. It is slightly larger because the eyes are not converged. Then for presbyopic glasses, we have to measure the near pupillary distance again. So it is measured when patient looks at near target 33 to 40 centimeters. Eye converge. So near pupillary distance is 2 to 4 millimeters smaller than the distance pupillary distance and important for prescribing reading glasses, bifocals and progressive glasses. What are the typical value for adult? For distance, it is 54 to 74, average 62. For near, it is 2 to 4 millimeter less than the distance pupillary distance. Example, Distance PD is 64, near PD is 60 to 62 millimeters. Now, what is the difference between monocular and binocular PD and how do we measure that? Binocular means the total distance between two pupils, which is approximately 62 millimeters. Monocular is measured from the nasal bridge to each pupil. This is much more accurate than binocular one. So in such cases, we measure from the nasal bridge and we write them separately. Like for OD, it is 31, OS again 31. Monocular PD is preferred in high prescription and progressive lenses for better centration. Now, what are the methods by which we can measure this? We can measure this by manual using PD ruler. Hold the ruler across the bridge of the nose and look at the pupillary center, distance between the pupillary center in both the eye. Then we also have pupillometer, which is much more accurate. You can measure using corneal reflex method, that is a Hirschberg technique, especially in children. And then digital device and apps are also used using photos and scans. What is the clinical importance of pupillary distance? Single vision distance classes, the distance PD is used. So if you are just using single vision, then distance PD to be used. If we are using only reading glasses, then near PD to be used. But if you are using bifocal and progressive, then near PD used for near segment and distance PD for the top part. If you give wrong pupillary distance, then patient may again complain of eye strain, blurred vision, headache, and double vision. So how do we prescribe? Like for PD for distance is 62. And if you have measured it as monocular, then OD 31, OS 31. Then PD for near is 59. Again, you can measure it by monocular, like OD 29.5 and OS 29.5. So summary says that distance PD, eyes are parallel, 62 millimeter average. Near PD, smaller by 2 to 4 mm due to convergence. Always note, monocular PD is for accuracy in presbyopes and high prescriptions. Coming to prescription formats. So we have two prescription formats. One is plus cylinder notations, which are used by ophthalmologists. It is a US tradition. Now, what is it important? Why it is important, and why US is using it? We will discuss its details soon. So in the plus cylinder notation, sphere is written first and cylinder is written positive. The axis corresponds to cylinder meridian. Then we always also have minus cylinder notation, which is used by optometrist and spectacle industry standard. The sphere is written first, cylinder negative, and axis corresponds to cylinder meridian. So you can see the example also. Then we have cross cylinder notation, where the two powers are expressed in two meridian at 90 degree, like plus 2 at 90, plus 3 at 180. Lens transposition, which we will study in detail soon. So it is a conversion between plus and minus cylinder. So you add the sphere and the cylinder to form the new sphere. So first rule is add sphere plus cylinder. This gives you new sphere. Then you change the sign of the cylinder. It gives you new cylinder and you rotate the axis by 90 degree. The thing to be remembered is that axis should lie between 0 to 180 degree, not beyond it. So for example, we have plus 2 diopter sphere, plus 1 diopter of cylinder at 90 degree. When we transpose, we add the sphere to the cylinder, which comes out to be 3. Change the sign of the cylinder. So plus 1 goes to minus 1 and also rotate the axis by 90 degree. So 90 degree goes to 180 degree. Clinical prescription example. First is OD minus 2.5 diopter sphere. This is simple myopia in right eye. OS plus 3 diopter sphere, simple hypermetropia in the left eye. OD plano minus 2 diopter cylinder at 180 degrees, simple myopic astigmatism in the right eye. Minus 2 diopter sphere minus 1 diopter cylinder at 90 degree. This is compound myopia. Both the powers are negative. And if they are myopic powers, sphere plus cylinder, it is compound myopic astigmatism. In the left eye, plus 2 diopter sphere plus 1 diopter cylinder at 180 degree. Both the powers are plus and sphere plus cylinder. So this is compound hypermetropic astigmatism in the right eye. Then you have plus 2 diopter sphere and minus 4 diopter cylinder at 90 degrees. So you have a plus power and you have a minus power also. This is a mixed astigmatism in the left eye. And for presbyopia, we have plus 1.5 diopters OU, means both the eye, or you write plus 1.5 diopter sphere at 2.5. Bifocals OD minus 2.5 add plus 2. OS in the left eye minus 3 diopter sphere and add plus 2 diopters. This is how we prescribe and this is how the different types of prescriptions are. Coming to clinical pearls for ophthalmologists. Now in case of kids, prescribe full hypermetropic correction in squint and amblyopia. We'll study in detail about this. In simple hypermetropia without strabismus, they are usually undercorrected by 0.5 to 1. In adults, myopia usually prescribe full correction and in hypermetropia give maximum tolerated correction. Astigmatism, even small cylinders can improve clarity. 0.5 and 0.25 also can contribute to the clarity. Always double check the axis as we have already seen. About 0.5 degree of rotation also can disturb the clarity. Presbyopia. Consider occupational need, computer versus near task. Progressive lenses are better than bifocals for cosmetically conscious patients. And isometropia, when the difference in the power of the two eye is more than 3 diopters, so such spectacles may cause anisoconia, which is difference in the image size. In such cases, we usually prefer contact lenses or refractive surgery. Then lens types in prescription. You can have single vision lens for near or for distance. You can have bifocal lens, that is the upper one gives the distance focus and the near one, the lower one gives the near focus. Progressive addition lenses, which are also called PALs, they give distance plus intermediate plus near vision. Prism lenses are used for strabismus. High index lenses for high power corrections like high myopia and hypermetropia. Photochromatic lenses are used for UV sensitive and they change the tint. Blue light blocking lenses for digital use. The sample prescription layout, as we have already learned, you should mention the name of the patient, age of the patient, date whenever you have prescribed the lenses, and also mention the occupation. Then you have the right eye prescription, which is always written first. So OD, right eye, even in case when OD is not mentioned, the first prescription should be considered as the right eye prescription only. So right eye is plus 2 diopter sphere and minus 1 diopter cylinder at 180 degree, giving a visual acuity of 6.6. Left eye is minus 1.5 diopter sphere and minus 1.75 diopter cylinder at 170 degree, giving a visual acuity of 6.6. Addition of plus 2.5. Then also mention the pupillary distance, binocular 62 millimeters. Lens type to be used is progressive blue light filter, and it should be signed by the doctor of the ophthalmologist. So every detail should be mentioned in your prescription. Not even a single detail should not be left out, as each one of it has its own importance. Now, what is the difference in prescription in US versus rest of the world? So in US, ophthalmologists usually use plus cylinder format. In Europe and India, optometrists and optical shops, including ophthalmologists also, they use minus cylinder standards. UK accepts both. So why is that the US ophthalmologists used plus cylinder prescription? So early ophthalmic refraction, which started in 19th, early and 20th century, was done with trial lens set and ophthalmic refractors that only contained the plus cylinders. So the ophthalmologists who got trained in US traditionally learned to write the prescription in plus diopter notations. And many US teaching hospitals and textbooks continue this convention for historical continuity. Also in ophthalmic surgery, like in toric IOLs, keratometry readings, corneal powers are always often expressed in plus cylinder form. So ophthalmologists are used to this. Now, why in India and most of the world uses minor cylinder? Optometry as a profession grew later and was strongly tied to optical industry, lens manufacturers, and spectacle workshops. Spectacle lenses are easier to grind and produce in minor cylinder form, so optical labs standardized on minor cylinder. Optometrists and dispensing opticians in India, UK, Europe, Australia therefore usually prefer minor cylinder notations. And since most ophthalmic practice in India overlaps with optical dispensing, minor cylinder notation became the default in clinics and shops. Now, what are the common prescription errors? The major blunder which we can do is in axis notation. This can harm or make the patient unsatisfied a lot. Then we usually forget to measure the pupillary distance, which is again very, very important. Giving full hypermetropic correction in adults can produce a lot of eye strain. Over minusing children, risk of accommodative problems. So these are some of the major mistakes which we can do in our prescription and should be kept in mind. Not specifying the prism base direction and not differentiating whether it is a cycloplegic versus subjective refraction. Now, coming to spectacle prescription in pediatrics, which is little tricky. So, the principle behind it that always do cycloplegic refraction or either with cyclopentolate, atropine or homide. Prescribe glasses based on the age, visual acuity, strabismus and symptoms. If these four factors have to be kept in mind. Now, what is our goal in prescribing glasses to kids? It is to prevent amblyopia and support normal visual development and maintain the binocularity. Now, what are the general guidelines of prescribing lenses to pediatric population? So, first, in case of hypermetropia, small degrees are common in infants. These are physiological hypermetropia. So, when to prescribe? When there is large amount of hypermetropia, when the patient complains of decreased vision, when patient has strabismus, especially in esotropia, and symptoms of headache, asthenopia, poor school performance. Now, few rules which we have to keep in mind. The first is in esotropia, prescribe full cycloplegic hypermetropic correction. And in fact, this correction has to be prescribed on the same day when you do the cycloplegic correction for the better acceptance. And in asymptomatic hypermetropia without strabismus, we have to undercorrect it by 0.5 to 1 diopter. So if a patient, since the pediatric population already has some physiological amount of hypermetropia, so when to prescribe, this table has to be kept in mind. If the child is less than 1 year, more than 6 diopter of hypermetropia and there is no strabismus. So if the hypermetropia comes out to be more than 6 diopter, then only you have to prescribe. But if the patient has esotropia, then you can prescribe lenses after 0.25 diopters of hypermetropia. Then when the child is 1 to 2 years old, only prescribe lenses when the hypermetropia comes out to be plus 5 diopters in absence of strabismus and plus 2 diopters in presence of esotropia. When the child is 2 to 3 years old, hypermetropia more than 4.5 diopter with no strabismus. And if child has esotropia, then hypermetropia more than 1.5 diopters. More than 4 years, when the hypermetropia is more than 3.5 but no strabismus, or the child has esotropia plus 1 diopter of hypermetropia. Only in these cases, we have to prescribe we have to give the full correction. So in all esotropia, we have to give the full correction. In asymptomatic hypermetropia, check the age of the patient, look at the table, whether we should prescribe it or not, and always undercorrect it by 0.5 or 1 diopter. Then in case of myopia, myopia is rare in less than 2 years. It is more common in school-going children. Prescribe only if high myopia, more than 5 diopters, then you have to prescribe only at any age. If it is a low, moderate myopia, if it reduces distance vision or causes squint, then only prescribe. And if it is a progressive myopia, like frequent follow-ups and full correction is needed, then prescribe. So oblique axis. So more than 15 degree off 90 or 180 degree or asymmetry between eyes, then only you prescribe the spectacle as early as possible. So in infants, astigmatism of less than one diopter is normal. So when to prescribe? In less than 1 year, if the astigmatism is more than 3 diopters and the axis is more than 15 of 90 or 180 degree. Then in 1 to 2 years, if the astigmatism more than 2.5, in 2 to 3 years, astigmatism more than equal to 2 diopters, and in more than 3 years, if astigmatism more than equal to 1.5 diopters. So these are the indication of prescribing the glasses. Then anisometropia, difference between the eyes, very important risk factor for amblyopia. So prescribe in amblyopia and give full correction in case of anisometropia. So what are the types of anisometropia? We have hypermetropic anisometropia when the sphere is more than equal to 1.5 diopters. In case of myopia, when it is more than or equal to -3 diopter, and in astigmatism more than equal to 2 diopters. These are the cases where you have to give the full correction. Then aphakia or pseudophakia in children, prescribe full correction immediately, usually with contact lens or spectacles, and do not forget to add bifocal for the near at plus 2.5 to 3 diopter. Now, what are the practical prescription pearls in case of pediatric population? Infants and toddlers, they prescribe soft elastic frames. These are baby glasses. Bifocals in children for accommodative esotropia with high AC by A ratio. This we will discuss in detail. Flat top bifocal segment at pupillary center. Progressive lenses are not prescribed in less than 10 years of age. Contact lenses are indicated in anisometropia of more than 3 to 4 diopters in aphakia or keratoconus. Myopia control, we have atropine drops of 0.01 to 0.05%. Orthokeratology, bifocal progressive may be considered. Now, as we have seen that bifocals are also prescribed in pediatric population where the AC by A ratio is high. So what is this? Let us see a little detail about it. AC by A ratio stands for accommodative convergence to accommodation ratio. It measures how much convergence, that means eye turning it, occurs per unit of accommodation. Many times we hear from patients when they say ki kuch bhi, whenever the child looks at a near thing, he or she squints. So that is high AC by A ratio. So that you have to see how much is it. Means that high AC by A ratio means that for a small amount of focusing accommodation, the child's eye turn a lot more than normal. This usually typically presents as esotropia, inward deviation at near, even if the eyes are straight, or less turned it at distance, often seen in accommodative esotropia. So why bifocals are used in such cases? In an accommodative esotropia with high AC by A ratio in the child, be aligned for the distance for regular hyperopic glasses, but still crosses at the near because the near work requires more accommodation, excessive convergence. So bifocal glasses with near at, they reduce the need of accommodation at near, thus reduces accommodative convergence and aligns the eye at near while maintaining the distance correction. So what is the mechanism of bifocals in AC by A ratio? So distance part is corrected by hyperopia. It controls the distance deviation. The near segment or the plus add, it decreases the accommodation, thus decreases the convergence and keeps the eye straight for reading or near work. Example, plus 2.5 diopter add may prescribe for near. Then indication, children with accommodative esotropia who are orthophoric or well aligned at distance with hyperopic correction but still have esotropia at near due to high AC by A ratio. So this is an indication of bifocal glasses and it is often seen between 3 to 7 years of age when child starts doing the near task. So what are the practical aspect of this? Lens type. We usually prescribe flat top or executive bifocal. The segment is placed high, bisecting the pupil. So this has to be kept in mind that in the executive bifocals, the segment should bisect the pupil and ensure that child looks through it when reading. Then add a power of plus 2 plus 3 diopters. Many children may outgrow the need as AC by A ratio normalizes with age and regular strabismus checkup is essential. Now, what are the pros and cons of this? So when they use the bifocal glasses, it aligns the eye both for distance and near, and it prevents amblyopia and thus help in binocular vision development and may avoid or delay the strabismus surgery. And what is the disadvantage? Cosmetically less appealing. Children may resist using bifocal properly because that upper end should bisect the pupil. So the alignment may not be there throughout the day. They might not use them properly. And some kids eventually require surgery like medial rectus recession with posterior fixation if the deviation persists despite bifocals. So example is a 4-year-old child with esotropia plus 4.5 diopter of hypermetropia. So child has esotropia along with hypermetropia. What is indicated? Give full correction, full 4.5 diopters. Now 8-year-old child just has myopia. So minus 2 diopters, you can give full correction for distance. 3-year-old child with anisometropia. Again, when the anisometropia more than 3 diopters, we have to give full correction. Then 5-year-old child with astigmatism, which is plus 2 diopters at 180 degree plano, and the left eye, in the left eye we have minus 2 diopters is 175 degree. Again, give full correction. Now, what are the mistakes to avoid? Prescribing partial hypermetropic correction esotropia, it can worsen the squint. So whenever the child has hypermetropia along with esotropia, we have to give full correction. Then if you ignore the anisometropia, the risk of amblyopia is very high. Not mentioning near correction in aphakic children, over minusing myopia, causing accommodative stress. These major mistakes have to be kept in mind or should be avoided while prescribing glasses to children. So this is a sample pediatric prescription. So the name of the patient, age of the patient, date of prescription, followed by right eye first, plus 4 diopters, left eye plus 4.5 diopters. Diagnosis, since it is an accommodative esotropia, full correction. Then pupillary distance, 54 millimeters. Lens should be single vision polycarbonate because these are impact resistance. Again, we will see about this. And full time, you advise them to wear because many a times the parents ask the question, key, for how long should child wear? Should he wear only in school or while watching TV? So you have to advise them that these spectacles have to be worn full time. And then you sign along with your credentials. Then what are the spectacle lens materials which are available in the market? As we have already noticed that in our OPDs and in our clinics, many times patient ask about the materials, or in special cases like when the patient has high myopia or has some special according to profession, how can we prescribe the type of the lens which they can use? So classification of spectacle lens material. One is the crown glass, the glass, which is a traditional lens material which is made up of silica, soda, lime, and metal oxide. Then we have plastic, which is organic lenses in plastic. Then we have CR39, Columbia resin 39, allyl diglycol carbonate polymer. We also have polycarbonate and Trivex, which is PPG industry urethane-based monomer. We'll see a little more about this. Then we have seen that we have glasses, we have plastics. In the plastic, we have 3 type of plastics, CR39, polycarbonate, Trivex. We have some high index materials which are especially used in high myopes or high hypermetropes to decrease the thickness. So these are modified glass or plastic with high refractive index. Then you also have specialty materials like photochromatic materials, polarized material, and coated lenses like anti-reflective and scratch resistance. So talking about materials in little detail, first comes the glass, crown glass, which was traditionally used. So what is the pro? What is the advantage? Excellent optical quality, high Abbe number. What is this Abbe number that we will see? Then you have minimal chromatic. So this Abbe number means the more the number is high, the chromatic aberration will be less. They are inversely proportional. So in glass, we have minimal chromatic aberrations. Naturally, they were scratch resistant and they were very cheap. Now, what are disadvantage? They were very heavy, high density. They were brittle, risk of shattering and dangerous in trauma, and poor UV absorptions. So rarely used today. Sometimes it is used in very high powers. Why? Because they are made up of high density materials, so they can be thinner. Then coming to plastic, the first plastic, standard plastic, is CR39. Now, what are the advantage? They are very lightweight compared to glass, good optical quality. Again, the chromatic aberrations are less in this also. Easy to tint and coat, safer than glass because they do not shatter. Disadvantage, they are scratch prone, thicker than high index lenses in high powers. So use most routine single vision bifocal lenses which we use are made up of CR39. Next plastic is polycarbonate. So it is, what is the advantage? Extremely impact resistant. So they can be used in safety goggles, sports glasses, inbuilt 100% UV protection. Again, very important for sport glasses and safety goggles. Thin and lightweight. What is the disadvantage? Poor AB number, which means high chromatic abrasions, and they can be easily scratched, must be coated. So they can be used in children because they are high resistant. Then monocular patients, again, safety, lot of safety. Athletes, again, for the safety purpose, and industrial workers, again, for the safety purpose, and 100% UV protection. Then third material is Trivex, which is again a plastic. So it is again impact. Advantages: impact resistance, similar to polycarbonate, can be used in safety material. Better optics, but the optics are much better. In polycarbonate, we have seen the chromatic aberrations were high, but in this case, it is less. It is very lightweight, low density, UV protection. And a disadvantage, more expensive than CR39 and polycarbonate. Uses premium lenses for children because safety is there, chromatic aberrations are less, it is light, and it gives UV protection. Can be used for pilots, military, and sports. Then comes the high index plastics. So what are the advantage? They are thin flat lenses which give better costnesses, especially in high powers. Lightweight compared to the glass, but they give lot of chromatic aberrations. They are expensive and they can reflect more light. They need a anti-reflective coating. So they are used in high myopia, high hypermetropia, and anisometropia. So this tables compares all the type of material which is available. So a little bit about it, that the impact resistance is very low in crown glass, but it is very high polycarbonate and Trivex. So these are the safety materials in we can use in children or in sports or industry workers. Scratch resistant is very high in glass. UV protection is again high for polycarbonate and Trivex, and cost is higher for the Trivex and high index material. It is low for the crown glass. Then chromatic aberration is least in polycarbonates. So these are the advantage and disadvantages which we can keep in mind while prescribing the glasses or while suggesting the type of material which they can use depending on their profession and depending on the age to the patient. Then there are also specialty materials like photochromatic lenses, which contain silver halide crystals, which darken in UV and clear indoors. What are the advantage? Convenience, the indoor and outdoor. Then disadvantage, slow transition. It doesn't darken in cars because UV is blocked by windshield. It is used in patients both for indoor and outdoor needs. Polarized lenses, they are filter horizontal glare. So light is reflected, whatever light is reflected from water, snow, and road are it gives protection against the reflected light. Advantage, improves contrast, reduces glare. It can be used during driving, fishing, or water sports. Then we have coatings like anti-reflective coatings, which reduces glare, improves cosmesis. Scratch-resistant coating, especially for CR39 and polycarbonate. UV coating for improving protection. And blue filter coating to reduce the digital screen glare. Now, what we need to prescribe in children, what is best for children is polycarbonate and Trivex, which is available with like Essilor and Hoya Phoenix. Then in high myopia, high hyperopia, we need high index material like Zeiss 1.74 and Essilor Stylus. For industrial material workers, we need some protection glasses like polycarbonate available in the by 3M Safety and UVEX. Then cosmetic conscious patient, we need high index plus anti-reflective coating. So it is Crizal Sapphire or Zeiss Duravision. For outdoor workers, photochromatic polarized like transitions, Hoya Sensity. And for routine use, you can use CR39 like Essilor, Orma, and Hoya Standard. So what are the clinical indications by material with company brands? So in children, as we have seen, polycarbonate and Trivex are much better, which are provided by Hoya Phoenix, Zeiss, Trivex, Essilor, Airwears. High myopia, high hyperopia, high index plastic, Essilor Stylis, Zeiss, high index, Hoya. Then industrial workers, we need polycarbonate, which provides safety like 3M safety glasses, Uvex by Honeywell, Essilor, Airwear safety. Cosmetic conscious patients, high index plus AR coating, Cecilia Crizal, Sapphire, Zeiss, Duravision, Hoya High Vision. Outdoor workers, photochromatic and polarized, transition, SLR, Zeiss, Photofusion, Hoya Sensity. Then routine everyday use, CR39, affordable, good optics, lightweight, SLR Orma, Zeiss Classic, Hoya Standard, CR39. So keynotes, SLR, Luxottica, Zeiss, Hoya, and Nikon are big four in premium ophthalmic lens worldwide. 3M, Uvex, Honeywell in industrial safety spectacles. Moijim, Ray-Ban, Oakley, Essilor Luxottica Group, leaders in polarized outdoor lenses. Now, what are the effect of material on vision? As we have seen, there is the Abbey number, which is chromatic aberration. Lower the number, more color fringes, distortion in periphery. Polycarbonate has worst chromatic aberration. Weight and comfort, high refractive index means thinner, but not always lighter. It depends on density. Trivex is lightest and most comfortable. That is why prescribed in kids also. Impact resistant, again in kids, critical in children and monocular patients. So polycarbonate Trivex. Cosmetic appearance, high index looks thinner and flatter in high powers. UV protection, least with the glass, excellent with polycarbonate and Trivex. Again, quick comparative material, which we have already seen. Then the newer technology comes for control of the high myopia. So we have specialized spectacles like defocus incorporated multi-segments, slit halt technology, slide glass vision dot spectacles, and promotional visual for slide glass vision dot lenses. So what are these? Coming to DIMS, that is defocus incorporated multi-segment, which is provided by Hoya MyoSmart. It is a central optical zone with peripheral honeycomb pattern of plus 3.5 defocus segment. So mechanism with which it controls the myopia is that provides a simultaneous clear central vision with peripheral myopic defocus to slow the eye growth. Then the next comes a stillet, which is halt technology, highly aspherical lenslet target, which is by Essilor. So it has 1021 micro lenses, which are arranged in 11 concentric circles with 9 millimeter central zone. So it creates a volume of myopic defocus while preserving the visual clarity. Then we have dot diffusion optics technology, which is side class vision. Thousands of microscopic light scattering dots are distributed across the lens surface to diffuse the contrast. So the mechanism is based on contrast theory, thus modulating retinal contrast to slow the axial elongation. So these are the 3-4 options which are nowadays available for myopia control. So again, comparing this, so we have these 3 technologies which we have already discussed. Now coming to the presbyopic spectacles, we have single vision near glasses only for near editions and used for reading, sewing or desk work. Advantage is wide field for near vision, cheapest and simple. Disadvantage, it cannot be used for distance, need to be removed or changed for walking or driving. Best for patients who do not need distance correction, those who read occasionally. Then we have bifocal glasses. So there are 2 distinct optical zones. The upper one is for distance and the lower for near. So we have 3 types of bifocal glasses. The D segment, which is flat top bifocal, most common. Near segment shaped like flat top D. And the round segment near zone is round, less conspicuous. Executive bifocal, Franklin split. The entire lower half is near vision and wide field of near vision. Advantages, can see both distance and near without changing spectacle. Disadvantages, image jump at the segment. No intermediate correction, cosmetically obvious. Best for elderly patient, teachers and shopkeepers. Then you have trifocal which has three zones: the upper, middle, and the upper is distance, middle is intermediate, and lower is near. It provides clear vision at all the three distance. Disadvantage is more visible lines, adaptation issue, less cosmetic. Best for patient needing clear intermediate vision like computer users and musicians. Then we have progressive additional classes, which are PALs. These are continuous gradation of power from the top, middle to near, which is distance, intermediate, near. No visible segment lines. So near power progressively increases down the lens and provides all distances, distance, intermediate, and near in one lens. Advantages: cosmetically they are better, smooth transition, one pair covers all distance. Disadvantage is the narrow intermediate near field, requires adaptation, head positioning is important, and it is more expensive. Best for active presbyops professional, cosmetically conscious patients. Then occupational, based on the occupational, we have computer office lenses. These are modified progressive lenses which are optimized for intermediate and near, provide wide comfortable field for desk. Double D occupational lenses. The distance zone is middle. Near segment is at top and bottom. It is used by mechanics, electricians, need near vision above the and below the head. Digressive and enhanced readers, essentially reading glasses with some intermediate power, good for office work. And then bifocal safety glasses for industrial workers, combining safety material like polycarbonate with presbyopic correction. Coming to the last topic of transposition, which we have discussed a little bit earlier also. What is transposition in ophthalmology? It refers to changing a cylindrical lens prescription from one form, that is plus or minus, to the other form without actually changing the optical power of the lens. Example, +2 diopter of sphere and -1 diopter cylinder at 180 degree can also be written as 1 diopter of sphere and +1 diopter of cylinder at 90 degree. So if you look at this, the prescription might appear different, but the optical power is same in both the cases. Now, why do we need the transposition? First is different notation system. As I have already mentioned, that the notation system are different in different countries. So depending on that, the prescription might appear different if you look at it. But when you transpose, the optical power actually remains same. So we have seen that USA and some country use plus cylinder notation. India, UK, and many other countries use minus cylinder notation. So spectacle prescription need to be written in the system that matches the laboratory or the region. Example, if you examine in plus cylinder, but the spectacle lab only accepts the minus cylinder, you must transpose. Then ease of comparison across prescription. So patient might bring old prescriptions written in minus while the refraction gives plus cylinder. So when you want to compare the axis where cylinder changes accurately, you need to transpose into the same format. Without transposition, it can appear as there is a huge prescription change, and when in reality, it's the same power in different form. Then optical consistency, some instruments like autorefractors,
I think,
keratometers, and
Dr. Prateeksha, we should wind up because you've already mentioned in great detail about transposition, and I'm sure each one of us know about it. So I
okay,
think
ma'am.
we can conclude, or maybe if you have something other than this to present, please do that.
Sure, ma'am. So for optical consistency, then again, it is easier for spectacle and contact lens fabrications, and astigmatism correction in surgical planning, which we have already discussed. Also, it reduces the clinical errors. So what is important to keep in mind is transposition does not change the does not change the lens optics, only it changes the way of writing the prescription. The method of transposition I have already discussed. Then what are the advantages? Again, the universal understanding, standardization, flexibility, and examination tool. Disadvantages: errors in axis rotation might occur when you do not put it correctly. Then mistaking the sign of cylinder, confusion for the beginners, and not all clinicians use the same formats. So I think that's all. Thank you, ma'am.
Yeah, thank you, Dr. Prateeksha, for a wonderful talk. It was really exhaustive and it really, I think, took a lot of effort on your part to, prepare such a vast topic in such a short amount of time. So I would just like to ask you one question that, these days all of us are giving presbyopic glasses and we are prescribing a lot. By presbyopic, sorry, glasses, I mean progressive glasses. So how do we decide? And like the patients, they come and ask you that which glasses, because they come in a range of, from 9-10,000 per pair to 90,000 per pair. And sometimes, sometimes it doesn't suit them. So how do you, which materials should we be choosing, or what is the easier way out to how to counsel the patient? Like Dr.
Ma'am, what?
Karika ma'am, if you would like to share anything about it.
Do you speak to me, Deepak? Did you address me? I'm not very sure. Do you
Yeah,
said
yeah, I'm asking ma'am, like patients
yeah.
come.
So,
Yeah.
Prateeksha, would you like to answer that question, or Kritika, would you like to also answer? She has asked a very specific question that, a lot of people come along and ask that, ma'am, like lots of people, lots of optical shops, the costs are very high.
Yeah.
So, what would you like to? Would you like to tell them that no, you go for the highest one, or you go for the lowest one, or you go for the cheapest one? See, very important. Can I answer the question therefore, Deepak? In
Yes,
my
ma'am. Yes, ma'am.
whatever
Please.
knowledge
Please.
that I have, and for having practiced for so many years, number one is one must look at the economics of it. If a patient is not able to, pay for a particular thing, then in that case, one should never tell that person that no, you have, unless the patient really requires it. Let's say, for example, the person is a sportsman, or let's say the child is very, very interested in games. Then, in that case, as Pratiksha said, what would be very essential would be to give a polycarbonate glass. Although these glasses are extremely expensive. So then you have to impress upon the child and upon the parents to tell them that this is essential for your child. And the child that please don't keep breaking them, otherwise it's going to cost your parents hell of a lot of money. That's very important. Second is, suppose, for example, a person comes, it's a farmer, and a farmer has, okay, he's not a rich farmer, is a normal farmer from, let's say, an Indian village who's just come to you for cataract surgery, and then he's taking classes. So, again, that has to be known that if you tell him that, no, you go ahead and take progressive classes, you think it's going to help him? No, he's not. It's not going to. He probably uses only his glasses when he's doing some kind of near work. Therefore, we have to be very judicious when we are prescribing our glasses and the type of glasses. What is essential is that for children, as much of the best quality and the way the fixation, I mean, Pratiksha has gone into real lovely details of it and of what type of glass to be used, especially for children, that must be definitely kept in mind because I think if we don't look after the health, the ocular health and the refractive health of our children, then we'll be doing them great injustice. Next comes, let's say, computer users. Computer users now, where everybody is a computer user, let's say 50 to 60% of our clientele is the young people who are working on computers. In that case, definitely, when I have had people coming and ask me, ma'am, shall I take UV protection? Shall I do this? Shall I do this? I have given them the answer that I gave my son because I know they're for 10 to 12 hours, they're on the computers. I said, take every bit of the advantages of whatever is being prescribed, for example, even UV protection, etc. Please take it because even if it provides you 1% uh, uh, advantage, I think that would be good for you, for your ocular health. It's for that reason. Besides, of course, there are other things, but I think those are the things that I will definitely look into while prescribing, while giving a person the amount of money that he needs to spend on his glasses. I would put the best glasses for children because I think they're really required. Best glasses of the finest quality of the time that they require, material that they require for sports people, and of course for the digital users in order to protect their eyes. But for example, a housewife who is not into some kind of work, or a farmer, or let's say a person who's not into too much of studies, not into, so this profession will definitely count. I think I have now expanded it quite a bit.
Yes, ma'am. Thank you, ma'am. And Dr. Pratiksha, last question from my side would be, at what power do you decide, like in children, whether to prescribe Stellest or, any kind of myopia control glasses. Suppose a family can pay, they don't mind, but they, sometimes they do ask that how to prevent the power to be increasing. So they want some solution. So what is the cutoff power that you would like to, start using these glasses, or maybe atropine drops? I don't know. I've seen that the patients are usually not very compliant for it. So glasses are something which we can offer them. So what is the ideal power that we should, or frequency of change in power? So what is the
Ma'am,
consensus?
as far as I know that there are criterias with every technology available. They have fixed power of glasses. Like the range is not available for all the glasses. Like for dots, it's a different range. So that we have to look into. And the second thing is that these are only prescribed for progressive myopia, not for the all myopes. Like even if the patient is high myope, but it is not progressing, and that progression is actually decided on the basis of the axial length. So only in the cases of progressive myopias, and then secondly, that power range should actually lie in the range of the technology which is
Right.
available on the basis of that. And then secondly, thirdly, ma'am, these technologies are really costly. Like they cost
Um,
around 16 to 17,000, and that has to be changed like maybe 6 monthly and yearly. That also we have to take into consideration. So the best thing for me is like atropine only, and as what I have learned from the pediatric ophthalmologist, that again the atropine has to be used for minimum of 2 years. And like usually what we do, we keep on prescribing atropine to every kid coming to our OPD, but it actually has to be prescribed again in cases of progressive myopia, which have to be noted maybe in the form of progression of the maybe in the form of progression of classes or in the axial length. So what
So
my
there
colleagues
have
are
been
practicing.
yeah. So there have
Yes.
been studies, and I had heard some international speaker also. Now they have compiled the data, ma'am, and they have categorically now it has been proven that the moment you stop atropine, the power returns to how much ever it was supposed to increase. And over a period of 10 years, they analyze either you continue it indefinitely, which is almost impossible. The moment you stop atropine, within 1 year, the power, it increases rapidly, and it comes to the actual power what the patient was supposed to have. So we are actually not sure whether how much that works, but these days many private practitioners, like we say, we see the prescriptions daily. First presentation they prescribe atropine as well as TELUS glasses. So that is why I asked you this question. Seen lot of
Thank you for starting this thing. So I think we'll take 2 minutes. I know we've already crossed time,
yeah.
but this is such an important question. Pratiksha, if you don't mind, I will talk about this because you've explained it very well. Well, one is, of course, progression. What progressive myopia? Yes, definitely. Second is that we never, that atropine, if it is taken on a higher dosage, I mean, rather instilled at a higher dosage, then the rebound effect is very high. If you take it at the dosage which is available in our country as 0.01%, then the rebound effect is not that great. That's point one. Number two is that Stellest classes in combination. If you find that yes, atropine is not really having its effect after seeing it, and you find that the number is increasing by at least 0.75 after every 6 months, then in that case, definitely you need to add Stellest classes. So I would also like to say that Pratiksha, thank you very much for putting in transposition, because you had talked about it initially, but I think you added some more slides because I had requested you to do so. And that was very, very sweet of you, because transposition is something that generally people don't talk about and generally don't know. So I think I'm definitely going to use your this entire presentation to teach all our DNB students and also put it across to the interns, the optometrist interns, because it's been an excellent class. Don't you think so, all of you?
It's
I think
fun.
she's
Yes, ma'am.
really done a
It was a
marvelous
pleasure.
job. Marvelous job.
Uh,
Because we've
Ma'am,
all
there is
learned
one
and
Uh,
question.
revised.
There is one question, ma'am. Ma'am, the question is about pre-presbyopes. Should we check convergence insufficiency with patient giving no systemic history or anything as such in a patient of pre-presbyope, or should we straight away give them glasses? As in, if a patient comes in the age group of 37, 38, should we go to give a the presbyopic glasses, or should we wait? With patient having no near vision tasks, the profession not involving the near vision task.
Whom are you directing the question to, dear?
Ma'am, I just I mean, I'm getting few patients nowadays who are in
Okay.
that age group.
Pratiksha, Deepa, any one of you to answer?
Sorry, ma'am, I didn't
I'm-
get the question.
Okay.
It's
I
okay.
think, see,
Can
first
you?
of all, it depends upon what type of refractive error the person has. As per what I have always understood and followed this rule, if a person is hypermetropic, the person is going to have early presbyopia. There's no doubt about that.
Yes,
37,
ma'am.
38, the person is going to presbyopic, and you give the least possible, let's say 0.75. A long time ago, we used to tell the patients to do the convergence exercises. Those convergence exercises also believed to decrease a certain amount of rapidity of your development of presbyopia. So that is one. Otherwise, generally, people are the myopes, of course, take it later, and emmetropes are approximately at this time. So presbyopic glasses, the number amount that is given is approximately 0.5 to 0.75, depending upon their need. Does that answer your question, Kritika? I'm not very sure
Yes, ma'am.
whether.
Yes, ma'am. Yes, ma'am. Yes, ma'am. Ma'am,
Can we
actually, we
wrap
had
up?
one more question
Yeah.
online, ma'am. A 4-year-old kid who came for a complaint with squeezing of eye while reading. While doing any work, the kid used to squeeze the eye. So on examination, everything was normal. PMT showed a hyperopia of +1 diopter. 4-year-old kid. Should we prescribe glasses or should we wait, ma'am? Because the kid has squeezing. Should we prescribe or wait and check in 6 months or 3 months and then decide on it?
I think we should prescribe. Patient is having if that squeezing is going with the glasses, then I think we should. But
So, ma'am, we can
squeezing
prescribe the
usually
glasses.
happens in cylindrical powers. I mean, that's what we routinely see, isn't it, ma'am?
See, one is that, a lot of children have a habit of doing
Habit,
something
yeah, you have to
to
rule that out.
just we first ruled out. Does the child really have a habit of squeezing the glass, squeezing the eyes? Because squeezing the eyes and making the eyes, slit-like is generally in myopia. So if you make your
Stereotypic.
eyes slit-like, then in that case, you are able to see better. So that's what they normally do. Then in that case, if it's a child, definitely the child should undergo a cycloplegic refraction and a proper one. And then after checking the refraction, only the child should be prescribed. So squeezing may be, as I said, it may be a habit. Second is one has to do a cycloplegic refraction to note what is the exact amount of refractive error before prescribing the child the correct number of glasses.
Okay, ma'am. Uh, that's all, ma'am.
So Deepa, we'll wrap it up.
Yeah, yes, ma'am. I think we should wrap up this session. And thanks a lot, Dr. Pratiksha, again, for
Thank you,
being
ma'am.
so
Thank
elaborate and a wonderful presentation. And thank you for having me, ma'am. Thank you.
Thank you once
Thank you
again,
so much,
Deepa,
ma'am.
Kritika, Pratiksha. You two are hats off to you. You really have done a marvelous job because it's such a, some may say, oh God, this topic, but then this topic has so much and so many
so much,
mistakes are
ma'am.
made. So
That's
today
true.
it was a wonderful re-revision for me also. So we
Mhm.
thank you very much. And the transposition thing, but I did not know that it was because of the difference in countries. The notation was because of America,
Right.
UK. And so that was wonderful information. All we used to know is that, yes, it's because that, the opticals find it easier to cut the glass in that
Make.
myopic fashion rather than hypermetropic. But thanks a ton, girls. It was really nice. Very, very nice. Thank you so much once again. Diksha, thank you very
Thank you,
much.
ma'am. Thank you,
Bye-bye.
ma'am.
Bye-bye.
Thank you, ma'am. Thank you.
Thank you, Deepa, ma'am. Bye, Kritika.
Bye, ma'am. Good night, ma'am. Good night, everybody.